Welcome to this explainer for Australian dizziness clinics. We are jumping right into the management of vestibular neuritis today, focusing specifically on acute, medical, and rehabilitation strategies. As vestibular physicians, you already know that navigating acute unilateral vestibulopathy, or AUVP, requires absolute precision. So today we're opening up a definitive procedural playbook. We're going to break down the exact clinical pathways, the hard evidence behind the pharmacotherapy, and the critical timelines for rehabilitation that will allow you to confidently manage these highly complex presentations.
Okay, let's dive right into this and address the absolute core tension we face with every single acute presentation. It's a classic clinical conflict, right? On one hand, you've got a patient in front of you experiencing severe, acute suffering. We're talking debilitating rotatory vertigo and relentless nausea. Naturally, our immediate instinct is to suppress those symptoms, make them comfortable. But, on the other hand, we know that heavy suppression directly stunts their neurological adaptation. So this is the core tension, balancing that immediate symptom control against the very real risk of delaying central vestibular compensation. How we navigate this exact tension in the first few days literally dictates the trajectory of that patient's entire recovery.
To manage that tension effectively, we rely on a clear clinical protocol built on 3 pillars: supportive care, targeted pharmacotherapy, and early vestibular rehabilitation therapy, or VRT. Now, while the first 2 pillars are absolutely essential for managing the acute crisis and getting the patient stabilized, I really want to emphasize right off the bat that the third pillar, early VRT, is by far the most evidence-supported and clinically impactful intervention we actually have. But of course, before we can get to rehabilitation, we've got to get the patient safely through that acute phase.
And that brings us right to our supportive care protocol. In the acute setting, your focus is squarely on symptom management and creating a safe environment. Short-term bed rest? That's appropriate, sure, but it absolutely must be capped at 1 to 3 days maximum. You also need to ensure adequate hydration, hook up IVs if necessary, alongside environmental modifications for fall prevention and getting them proper antiemetic coverage. But here is the critical warning. Prolonged bed rest is actively harmful. It critically delays central compensation. You've got to push for early, controlled mobilization as soon as the acute nausea allows for it.
So the crucial point here is the 72-hour maximum rule for vestibular suppressants. The evidence-based approach demands that we limit the use of these suppressants to no more than 72 hours, with active weaning starting as soon as it's tolerated. And keep in mind, that suppressor clock, it starts ticking at the very first dose. Leaving a patient on heavy suppressants beyond this window severely retards the central compensation process that we are so desperately trying to trigger.
Let's break down the actual pharmacology we use during this 72-hour window, which we've adapted from Table 5 of the literature review. Look at diazepam. It's a potent GABAergic suppressor at 2 to 5 milligrams, and yes, it's highly effective for acute vertigo, but it poses the highest risk to compensation. You absolutely must avoid it beyond 48 to 72 hours. Then we've got promethazine, a D2 antagonist. You need to use caution there with the elderly because of the sedation. Prochlorperazine is a great first-line antiemetic. It has minimal suppressive effects, but conversely, notice ondansetron down at the bottom. As a 5-HT3 antagonist, it provides excellent nausea control without those vestibular suppressive properties. This is your key transition agent. You can safely use ondansetron well beyond 72 hours to manage nausea without shutting down central compensation.
All right, moving from suppressants to targeted therapy, we absolutely have to discuss corticosteroids and antivirals. We anchor this to the landmark Strupp 2004 randomized controlled trial. This trial is basically the foundation of our current steroid guidance. It clearly demonstrated that methylprednisolone significantly improved peripheral vestibular function recovery. Get this, at 3 months, 83% of the steroid group showed recovery on caloric testing compared to just 58% in the placebo group. That is a clear physiological benefit. And, perhaps surprisingly for some, that exact same trial showed that acyclovir provided literally no additional benefit whatsoever over the placebo.
Now, what's really interesting about this slide is the distinct dissociation that was identified in subsequent meta-analyses. While the Strupp 2004 trial proved a physiological improvement in caloric function, later systematic reviews found that this doesn't strictly guarantee faster subjective symptom resolution. There's a distinct dissociation between caloric recovery and functional patient-centered outcomes, things like dizziness handicap and returning to normal daily activities. So the clinical nuance here is acknowledging this modest physiological benefit while weighing it against the overall risk-benefit calculation for each individual patient sitting in your clinic.
Consolidating all this evidence gives us a very pragmatic, practical recommendation for the acute phase. If your patient presents within 72 hours with a severe initial deficit, say a profound caloric canal paresis, and they don't have any contraindications, a completely reasonable regimen is oral prednisolone at 1 mg per kilogram per day, up to 60 mg, for 7 to 10 days, followed by a 10-day taper. But remember, the evidence does not support universal blanket steroid use, so shared decision-making is absolutely key here. Furthermore, because antivirals like acyclovir or valacyclovir lack RCT evidence of benefit, they're simply not recommended as standard care for routine vestibular neuritis.
So once we navigate the acute phase and get past that 72-hour window, we trigger the true long-term accelerator, vestibular rehabilitation therapy. The 2023 Cochrane Systematic Review provides level 1 evidence confirming VRT's absolute superiority over just watchful waiting. When VRT is initiated early, and by early I mean within the first 1 to 2 weeks, we see a massive 30 to 50% reduction in recovery time. This early initiation is the single most modifiable determinant of recovery speed and completeness. Do not wait for complete nausea resolution before referring your patient to vestibular physiotherapy.
And this brilliantly illustrates our holistic approach. Figure 8 from the clinical framework perfectly maps out how we integrate general supportive care, early VRT, balance training, and even those positioning maneuvers for secondary BPVP. This comprehensive approach is exactly what drives that necessary cerebral and brainstem plasticity. Because think about it, it's not just about waiting for the nerve to passively heal, it's about actively forcing the central nervous system to adapt to this totally new sensory reality.
To actually achieve that plasticity, a comprehensive VRT program has to incorporate 4 principal domains. First up, we've got gaze stabilization. This involves X1 maneuvers, where the head moves while the eyes lock on a stationary target, and X2 maneuvers, where the head and target are moving in opposite directions. The biomechanics going on here are vital. These exercises are intentionally generating a retinal slip error signal. That signal directly drives VOR gain adaptation. Second, we have balance retraining. This systematically challenges their static and dynamic stability. We're moving from firm surfaces to foam, tandem stance to eyes-closed tasks. Third is habituation. This uses repeated exposure to vertigo-provoking movements to basically dial down those maladaptive responses. And finally, the fourth domain is functional training, taking all these specific challenges and integrating them into real-world activities of daily living like walking and negotiating stairs.
Now, of course, prescribing the therapy is only half the battle, right? Execution is the other half. But the data here is incredibly encouraging. Patient-directed home exercises, when adherence is actually confirmed, achieve clinical outcomes that are completely equivalent to supervised, clinic-based rehabilitation. This is a huge point for patient counseling, particularly when you're managing geographically dispersed populations who can't just pop into the clinic 3 times a week. Emerging digital therapeutic platforms with structured exercise libraries and adherence tracking are fast becoming invaluable tools to ensure compliance and drive these equivalent outcomes.
Let's pull all this together and see how this builds into our definitive clinical pathway. Think of it like a procedural funnel. At hours 0 to 72, you are strictly managing the acute crisis, enforcing that hard 72-hour suppressor limit. Also within that first 72 hours, you're making your shared decision on corticosteroids for severe deficits. By week 1 to 2, as soon as that acute nausea permits, you are commencing vestibular rehabilitation therapy. And from there out, it's ongoing recovery milestone counseling, identifying any psychosocial risk factors, and always checking for secondary BPVV at your follow-up visits.
Ultimately mastering the specific, evidence-based pathway, tightly controlling those suppressants, making evidence-backed pharmacological choices, and aggressively pursuing early VRT fundamentally transforms patient recovery in acute unilateral vestibulopathy. By shifting our mindset from simply suppressing symptoms to actively driving central compensation, we mitigate long-term disability. So I'll leave you with this provocative question to think about in your own practice. Are your acute prescribing habits delaying your patient's recovery, or are they actively accelerating it? Thank you so much for joining this explainer. For more resources, be sure to visit AustralianDizzinessClinics.com.